Welcome to EconTalk, part of the Library of Economics and Liberty. I'm your host, Russ Roberts of Stanford University's Hoover Institution. Our website is econtalk.org, where you can subscribe, comment on this podcast, and find links and other information related to today's conversation. You'll also find our archives, where you can listen to every episode we've ever done going back to 2006. Our email address is mail@econtalk.org. We'd love to hear from you. Today is May 8th, 2013, and my guest is Austin Frakt. He is a health economist with educational background in physics and engineering. He has appointments with the Department of Psychiatry at Boston University School of Medicine, the Department of Health Policy and Management at Boston University School of Public Health, and the U.S. Department of Veteran Affairs. Since 1999, he has studied economic issues pertaining to U.S. healthcare policy, with a recent but not exclusive focus on Medicare and the uninsured. And lately, he's devoted more attention to comparative effectiveness based on observational data. He blogs at The Incidental Economist. Austin, welcome to EconTalk.
Thank you. Thanks for having me.
Now, given your interest and background, I thought you'd be the ideal person to talk about the recent results that have come out of the Oregon Medicaid study. And for those of you who haven't heard of that study, it's a very unusual and potentially influential study done by some very high-profile health economists. And Austin, you've been a very thoughtful commentator on that study as its results have been coming out. I want to start with some background on Medicaid, the program, the federal government program that also works with the states. How does Medicaid work?
Well, let's start just one half step before that, which is to say the first thing to know about Medicaid is that it's not Medicare. And I know a lot of people who aren't well-versed in the U.S. health system can get confused between the two. So just really quick, the first-order approximation, Medicare is a program for retirees or people 65 old and older. It does also cover some people with disabilities and certain other health conditions. But basically, if you remember one thing about Medicare, it's that it's for the elderly population. Medicaid, if you only know one thing about Medicaid, the thing you'll know is actually not true, but that thing would be that it's a program for poor people you can think of as near or around or below 100% of the federal poverty level, which, by the way, I have a 2008 figure in front of me, was about $10,400 for a single individual. So Medicaid is a program for poor people. However, I think the next thing you should know about Medicaid is that it's you can think of it as really two programs.
Austin, you said that's not true. You said it's
not.
Yeah,
that's what I'm getting to.
Okay, go ahead.
Yeah. The next thing you'd want to know is that you can think of it as really two programs put together. One is that it is a federally mandated program for people who meet certain conditions in addition to being poor, and these are people who are aged, old, blind, or disabled, or pregnant. So specific, they're called categorically eligible, so specific categories of people. So these people can get on Medicaid if they're both poor and meet one of these categories. And that's not everybody. There's a lot of poor people who are not blind or disabled or pregnant or old. They're just poor. And so the second thing that a Medicaid program can do, and this varies by state, is expand to include those other people who are poor but don't meet one of those categories. And so this will vary by state, and sometimes it involves certain waivers from the federal government to expand in certain ways. But it's separate from the sort of mandated core of the program. So one mistake people often make is they think Medicaid, we've got a program for the poor. It's called Medicaid. Everyone who's poor is on it, and no problem. They're taken care of. Well, that's not true. In many, many states, it's only people who meet certain categories. And this is one of the things that the Affordable Care Act, the new health reform law, is supposed to address, or was supposed to address. We can get into whether it will. Is that it was designed to expand Medicaid to include all poor people, regardless of whether they're categorically eligible right now.
So, if you are on Medicaid right now, either because you meet one of the categories, or you are in a state that expands coverage beyond those special categories, you're quote merely poor. What are the benefits? What happens to you when you use healthcare Does that vary by category, by state? But once you're on Medicaid, what happens to you?
So mostly your healthcare is paid for through the state program, and it varies by state what the details would be. There may be some cost sharing, a few dollars in a copayment for a drug or a doctor visit. There may be a small premium, and these things can vary by income. So if you're very, very poor, way down, well below the poverty level, maybe you'd have no cost sharing and no premium. If you're, at the poverty level or even a little above, some states expand above, maybe you'd have some of those things. But it's basically a healthcare benefits program, so it would cover hospitalization, doctor's visits, preventative care, prescription drugs. What it typically doesn't include, though, is dental or vision. So you will find many Medicaid beneficiaries or Medicaid enrollees who are getting much of their care paid for, but they have horrible problems with oral health. For example, their teeth are just in horrible shape, and that's an issue for them.
So if I'm a poor single parent and my kid's running a fever and I'm worried that she's got an ear infection and I'm a Medicaid recipient, what do I do? In my case, I've got coverage, health insurance coverage through my employer, and I take my kid to her pediatrician and maybe get a prescription, and that office visit is, I don't know what it is, maybe $20, and I pay a very large premium to have that privilege of a $20 visit, and my employer pays part of that as well. Now, give me that story when I'm a Medicaid recipient.
It's the same story, except as with many people's plans, there would be a network of doctors and hospitals that would accept the plan, and some may not. And that's true of many people with private coverage as well. So you could go to one of the providers that accepts the coverage and have your care provided there and largely or entirely taken care of cost-wise by the program.
Depending on your state, whether there's a copay, the things you talked about before, right?
Yeah. So, like I said, there could be small copays, and that's going to vary by income and vary by state. So one of the standard lines about Medicaid is if you've seen one Medicaid program, you've seen one Medicaid program. Yeah. There are 50 plus DC, so and they're all different in some way. So it's very hard to generalize without basically lying a little bit. An advantage of that diversity, however, is that it's something that can be studied. Studies have looked at that variation.
So let's get to the Oregon study, which has created it's been a great week or week and a half for maybe 2 weeks for empirical economics. We had the Reinhart Rogoff study, which we'll be doing something on in a few weeks here. But the Oregon study has created a firestorm of comments in the news and the blogosphere. So tell us what that study. Give us the background on the study and what it's trying to understand.
Yes. So this study, there's so many great things to say about the study, but let's just start with how it came about. So Oregon had closed the part of its Medicaid program that was for people who are just poor. It's got the mandated federal categories. That arm of Medicaid's got to keep going, but for budgetary reasons, they had closed new enrollment into their sort of expansion of Medicaid, and this is in the mid 2000s. And then they found, the elected officials decided and found some funding that they thought they could open enrollment to about 10,000 people in 2008. But they did something that, to my knowledge, no other state has done, or at least it's not common, which is they offered enrollment to people on a lottery basis. So they opened a lottery, and people could apply to the lottery and put their name on the list. And then they selected some number of people off the list. There's about 18,000. 30,000, I'm sorry. 30,000 people off the list out of 90,000 who applied to be permitted to enroll. And this was a random selection. And while this was going on, some investigators at Harvard and MIT heard about it on NPR, I think, and they said, "Oh wow, this is a randomized trial. You know, they're randomizing people into Medicaid, or they're randomizing them into the privilege of applying for Medicaid."
So the 90,000
and not
the 90,000 who applied, they didn't take the 30,000 sickest or the 30,000 richest or poorest. They just took a random 30,000 of the 90,000.
It was random, correct. It was random. And they said, okay, out of the list of 90, you 30 can apply, you 30,000. Now, not all of those 30,000 were, as it turned out, by the time they could apply, eligible. Some of them lived out of state. Some of them, their income was too high at the time of application, or for a variety of other reasons, they weren't eligible. Some just chose not to apply, maybe because they found other insurance or for some reason. So actually about 18,000 who were eligible to apply actually did. And then ultimately, when you get down to the study we're going to talk about, where they did some follow-up surveying and so forth, the study that we're going to look at actually only has about 6,000 people in the 6,000 people in the control group. Those are people who were randomized that couldn't apply, and then 6,000 people in the randomized to be able to apply group, of whom only about 25% actually enrolled in Medicaid. So it's a little bit confusing.
It's weird.
Out of all these numbers, at the end of the day, when you look at all the data collection, you've got 6,000 people in a control group, 6,000 people in I'll call it a treatment group, but I want to say what treatment means in this context is we're randomized to be permitted to apply for Medicaid.
But how many of them enrolled in the program are covered by it?
So then you have the enrollment group, which is a subset of that treatment group, and that's 25% of the treatment group, or about 1,500 people.
Okay.
So that's what the latest study is looking at. Those are the numbers, the basic underlying numbers on what they have.
And a little methodology here. So we've got the control group, and we have people who are enrolled in Medicaid. How do we the students of this program, how do we, the investigators, how do we monitor or assess their data, health outcomes, demographic variables, et cetera? How many times? What's the format for how we learn about what happened to them under these two experiences?
All right. So there's a number of data sources. So first, you have information that was provided just in the application process. That's very basic information. I'm not quite sure what it all was, but things like age and
sex,
just very basic. And then the investigators, they had a lot of cooperation from the state of Oregon where this took place, and they got administrative data. So these are things from the Oregon Medicaid system itself. When people enroll, they provide a lot more information, and they can look back over time to see if these people had enrolled in the past and get the whole history of Medicaid involvement with the Medicaid program for the sample they had.
And they know when they visit the doctor, they know, et cetera.
Yeah, I don't believe they had access to all that kind of medical records. But what they did do is they did go to hospitals. They did have hospital records. I'm not sure they had outpatient records. I didn't see that mentioned, but they had hospital system records. And they had, hospital discharge data. They also pulled in, for reasons that are kind of a detail, some credit data. Actually, that's not a detail. What is a detail is they got some food stamp and some cash welfare assistance data from the state as well.
But for the non-enrollees, the control group, how do they know stuff about them? Those 6,000. So there's 6,000 people who didn't win the lottery, and now they get contacted presumably by some health economists or the state of Oregon saying, "Oh, you've been chosen to participate in this survey." How do we get information about them?
Right. So all the things I just mentioned are just the administrative data, and they had that on everyone. So they had all that stuff I just mentioned on everyone. Then they went to both the treatment and control groups, and with mail and phone surveys, and the mail and phone surveys were done prior to this group published a paper last year, and this was done prior to that, and I don't remember the date, but let's just say it was in 2009 or 10 or something like that. So they surveyed everyone by mail and phone, and they got a 50% response rate in that survey. And in that survey,
which is very high.
Yes,
for a mail survey, it's ridiculously high. Obviously, they followed up by phone, and
they followed up by phone. And this is where they got additional data on healthcare use and costs and financial strain, health status and demographics. But this is all self-reported. So they weren't going to these people's, doctors and asking them. They were going to the people themselves and saying, have you visited the doctor in the last number of months or year? What happened there? I mean, it's all structured, but this is how it's done.
But they didn't show up with a blood pressure cuff and measure things directly from them. Not
in the mail and phone survey.
Correct.
Then.
Yeah, keep going.
So the data I just talked about, the administrative data and the mail and phone survey data, that was all available a year or more ago, and this group published a paper a year or more ago with that data. The most recent paper includes that plus in-person interviews. And the in-person interviews is where they collected biometric data. So this is blood pressure. They actually measured it. This is a blood sample, so they could get cholesterol levels, blood sugar levels. So this is a lot of really granular detail on the actual health of the individuals. It's almost like, I don't know quite how they did it, whether they did it with nurses or someone, but it's almost like having a doctor visit in a way. They just measured some basic things.
Reminds me of the NFL Combine. They did do a 40-yard dash, then the IQ test. Anyway, so they met them face to face. They gathered more data, and this is ongoing. Is that correct? So this experiment's still going, or is it over now?
So the data collection is over because I believe the state has subsequently expanded the program so that the lottery is not necessary. They're not randomizing anymore, and everybody who wants in can get in.
Did the economists protest? Hey, you're ruining our study. Come on.
Yeah, I know. It's true.
Yeah, that human subjects regulation's a bummer, isn't it?
What is forthcoming is there was some more data collection, more data analysis beyond what is reported in the latest paper. That's ongoing, and they expect to have more results. One thing they could do, I believe they are going to do, but I wouldn't swear by it, is you can monitor, for example, mortality down the road because you can get public death records. And so even though these people were once randomized and now the study's over, you can look 3, 4, 5 years down the road and see if the couple of years experience on Medicaid versus not made a difference on things like mortality, or that could be done. Whether they're going to do that precisely, I'm not sure.
So why has this recent set of results that has come out in the last few weeks, why have they been so controversial? What were the findings? Well, let's first, rather than talk about why they're controversial, why don't you summarize what the most recent study found, the most recent study of these data?
Okay. So there are a number of findings that were statistically significant, and I think, to my knowledge, are not controversial. And these are areas of, I'll just give you the broad categories and then we can dig into them. So they did a battery of analysis on financial protection. How much does Medicaid protect you from, high bills and devastating catastrophic costs of healthcare and so forth. They have a battery of results on access and prevention. So how much easier was it for you to see a doctor and get preventative screening and so forth? They have results on some results on health outcomes, both mental and some physical health outcomes that were statistically significant, and they have results on cost to report. And so we can go into some details on those. Those are not generally controversial. There's then a set of results on some additional physical health outcomes, some physical health measures that were not statistically significant. And it's those that are really the subject of debate.
Yeah, and summarize those.
So those are things like the effect of Medicaid on blood pressure, changes in blood pressure, cholesterol level, blood sugar control, which is related to diabetes, and medications for these things. And so when you look at all these things, and they're all, several of them are measured in a few different ways. But when you kind of look at the table in the paper, there's maybe a good a dozen or 15 or so results that are staring at you all about physical health in one table, and none of them are statistically significant. So it appears as if the study is saying that Medicaid is not able to have an effect across all of these health measures, and that the discussion over whether that's what the study is saying is what the debate is about.
So we'll talk about that, and then we'll talk about why it matters. But let's first just talk about these results. Now, I've argued, as have many people, that we ought to be more worried about health care than health insurance. Obviously, health insurance has certain aspects to it that are distinct from health care, but they're positive, like comfort and not fearing financial distress. But it's also clear that healthcare insurance doesn't keep you literally healthy. There are other ways to get healthy. There are a lot of factors that affect your health that aren't related to medical care and the use of the healthcare system, nutrition, genetics, stress, lifestyle, etc. So this is a big, messy area. But my general bias, which I'll get on the table, my general bias has always been that I really don't want to expand the current system that we have that allows people to spend other people's money, which then pushes up the use of medical care often without value and makes the whole system more expensive for everybody. Now, obviously, there's a lot of pieces to that I know you don't agree with, but I want to start with the point that it's not so shocking to me, even though I'm not a big fan of Medicaid, it's not surprising to me that in a 2-year study that it didn't find very much of an effect. That's not the claim, I would think, of the value of having health insurance, that over 2 years your blood pressure is going to drop, your blood sugar level is going to drop if you're close to diabetes or have diabetes. Are these really the measures that we want to judge the value or lack of value of a federal and state subsidy to healthcare for poor people?
Well, should we use these measures, or are you asking? Are people? Did some people think that we would see an effect here?
Both.
Well, so I'll take the second one first. I think that there's a great diversity of claims about this study, and in fact, though I haven't looked back myself carefully, I probably suggested a year ago that the proof was in the pudding in terms of whether health insurance affected health in results just like these. And in other words, I was looking toward this study to put to rest this discussion whether health insurance facilitated an enhancement of health or not. Now, when I said such a thing, I was not aware. I could have been aware, but I don't think I was aware of the precise measures they were going to look at. I was certainly not aware of what some of the baseline rates of these things were, and how much power the study had to detect changes if there were any. And so it's not. Now seeing the results and having looked at the actual numbers they had, I'm actually not surprised that that they weren't able to show an impact. Now, are these the right things to look at? No, I don't think so. Well, I'd say some of them are and some of them aren't. But I'm not a physician, so it's a little hard for me to judge. But I'll just look at diabetes in particular. We know clinically from clinical evidence that taking certain medications for if you have high blood sugar or diabetes really affects those things. I mean, it really moves the needle on your blood sugar and in terms of blood sugar control. And if health insurance facilitates greater access to those medications and people follow through, then you ought to see a result. As for blood pressure and other things, maybe you can make the same argument, but that's how I think the basic causal chain would go.
And what's the bottom line for you of these latest findings? Does it change any of your priors? What's it do?
It changed my prior on what I thought this study was designed to detect. So I spent the better part of this week digging into details on the design of the study and how it was powered, or how many individuals were actually involved, and what that meant for what it could measure.
Talk about what you mean by power, because that's a statistical term that
right.
Most people aren't familiar with.
So power is the strictly speaking, it's the probability that the way it works is you're supposed to do this before you do a study. You're supposed to say, we're going to do a study of insurance versus not insurance, and we hypothesize in advance that insurance will, let's say, move someone's blood sugar from whatever it is at baseline to some lower value. If it's elevated, it'll bring it down. Insurance will have that effect. It'll act through people who have high blood sugar and take drugs. Not everybody is like that, but on average, it'll have this effect. And you say what that effect is in advance, and then you design your study so that it has enough sample to capture that effect. If you design a study with 3 people, and you're expecting everybody to be cured from cancer, you're just not going to find that.
Well, because that's too big an effect to expect, likely.
Too big an effect. It's a combination of too big an effect and too small sample. If you instead say, I have 3 people with certain stage cancer, and the intervention is I'm going to give them a certain drug or certain radiation treatment, and 1 out of the 3 will be cancer free in 2 years, say. That may be a 30% response rate. Maybe that's reasonable to expect, but you wouldn't expect to be able to measure it with very much precision with a sample of 3 people.
Right. You want 3,000 or 3 million or
300. Yeah. But that's exactly right. So what is that number? You can calculate that number in advance. It's actually very simple, and you can do it with online tools, or you can do it in statistical software. This is a standard calculation for any application to NIH, National Institutes of Health, or any study within the VA that I do. You have to demonstrate that you have, quote, power to detect the hypothesized size that you think is reasonable. So you suggest that this intervention will have such and such an effect. Then you do a calculation saying, if it has that effect, we have enough sample, we're going to do enough data collection, or our databases are already big enough such that if it has conditional and it has that effect, we will be able to distinguish that from no effect. We have, the error bars are small enough, basically.
So just to take a everyday example for people who aren't used to these kind of arguments, let's suppose my hypothesis is that men are taller than women, which most of us are pretty sure is a true statement. So let's say we want to show that. If we take a sample of 6 people, it could be that the 3 men you choose just happen to be short men, and the 3 women you choose happen to be tall women, and it wouldn't be a very reliable finding if you found that the women were taller. But as you go to 3 to 6,000 men and women, the odds get larger that the finding that the men are in fact taller than the women is more reliable. I gave a bad example at first. I should have said when you chose 6, you chose tall men and short women. You wouldn't know if that was true by chance. That could just be that you chose tall men and short women. But if you chose 6,000, 3,000 men and 3,000 women, the odds that that's true by chance, your findings gets a lot less likely. So one way to talk about, you've written and others have written that this study was, quote, underpowered. Another way to say that is that the investigators presumed that the effects would be larger than they turned out to be. Is that correct?
They could have done that. I'm not sure that's exactly what happened. They could have either presumed very large effects. The problem with that hypothesis is that the effect sizes for which they are powered are enormous. I did actually do this calculation. So for example,
what does that mean?
one that I did was what this study found, the point estimate for the proportion of individuals whose blood sugar dropped below a value that's, there's a value of blood sugar above which you're considered diabetic or near diabetic. And they found that the proportion of people on Medicaid who had a blood sugar below that level, so they dropped from a diabetic or pre-diabetic level down, was 20%. So this is just the point estimate. So 20% of the people 20% fewer people in the Medicaid group had elevated blood sugar than in the control group. That's the point estimate. Yeah, big error bars, but that's the point estimate. So 20%. I computed that if that number had been 4 times larger, so 80%, if it had an 80% effect, then they would have been powered to have distinguished that from happening by random chance.
It would have been it could have been statistically significant.
Right. They would have been powered for that. But an 80% effect rate
huge. Yeah.
from just giving someone insurance, I don't think the investigators were thinking in advance, we expect 80%. What I think is much more likely and much more common in economics, economists don't generally do power calculations. In fact, before a year or two ago, I had never done one. Because what's more typical is an economist that says, well, we're going to study this issue. We have some data which is fixed in size. It's the size of the database. We don't do surveys generally.
We're stuck with it.
We're stuck with it. There's only, in macro, there's only so many countries in so many years. I'm not going to suddenly cook up 10,000 more country year combinations. So I'm just going to go in and see what I can find. And some of it will be statistically significant because it has a big effect, and some of it won't be. And that's just end of story. We don't do a power calculation because we can't change the effect size. That's quote nature or the system. We can't change it. And in economics, if you can't change the n, size your sample, there's no point in a power calculation, except one point in a power calculation is this even worth investigating in the first place? Am I likely to come up with informative results? Are my results of any value? Because you could know that in advance if you thought you had a reasonable guess at an effect size, or at least a bound on it. So it's just hypothesis. What I think is more likely in this circumstance is the investigators had a great opportunity. It's a great study. They did a lot of good things. The design here is fantastic. We didn't go into some of those issues, but we could. And they actually pre-specified all their analysis. So this wasn't a fishing expedition. They put online, here's what we're going to do. Yeah, it's exceptionally impressive. And then they just went out and did it. If they did a power calculation in advance, I've never seen it. I don't think it exists anywhere publicly. And chances are they didn't. I'm not sure I would have.
But the bottom line is that on a number of predetermined important health measures, and I would actually call them proxies. Maybe we'll come back to that later, but it's not actual health. It's things that, as you said, biometric measures. They're things like blood pressure and blood sugar, et cetera. They didn't find any effect. Now, they did find some effects, though. So why don't you talk about what they found that was significant in them?
Well, the headline of big effect is financial protection. So out-of-pocket medical expenditures that were above 30% of income. So this is their kind of definition of a catastrophic expenditure. That was basically dropped to zero. I think it dropped 80% from a baseline rate of 5.5% down to 4-point-something%. So Medicaid virtually wiped out the chance that medical expenses are gonna clobber you. That's completely predictable given what Medicaid is, or health insurance in general. The likelihood of medical debt came down by 20%, and the proportion of people borrowing money or not paying off medical bills was cut in half. So a lot of financial protection. That's actually to be expected, and those are reasonable. Big increases in access, and this kind of relates to financial protection. If you don't have to pay for care, and it's quotes, someone else's money, it is. You're going to much more readily go in and get preventative screening. So they have big increases, in women getting pap smears and mammography. 20% increase in probability of getting, quote, all needed care. I'm not sure if that's self-reported or they defined what they meant by all needed care, but big increases in access. And then there's some statistically significant changes in health outcomes. The big one there is depression diagnosis. So right after the lottery, they could look at who was diagnosed for depression, and they found that there was a 30%. They found that there was an increase in probability of depression diagnosis right after the lottery. But over time, the people on so this is why would there be a big increase in depression diagnosis? This is just an access thing. So more people are going to the doctor, and they're getting diagnosed. There's higher rates of diagnosis, and one hopes, but I don't know whether all those additional depression diagnoses are real. These people are actually depressed, or whether it's just a increase in diagnosis.
Yeah, we spent some time on this program, as I think you know, talking about the challenge of correctly diagnosing depression, the interests of the pharmaceutical industry in encouraging diagnosis of depression, et cetera. So that's a tricky thing. But they did find an increase in diagnosis, but more than that, right?
And then a decrease over time in people screened for diagnosis. So they have an increase in people diagnosed, and then they with their interviews, they could do a screening for diagnosis later through a series of questions that are validated for this purpose, and found that the screening positive rate came down 30%. So people were diagnosed with depression, and then they were it came down by 30%, whether they were actually, by this measure, depressed later on. So this is an improvement in depression from post lottery diagnosis rates.
Right.
And then they had an improvement. Go ahead.
Which we don't know exactly what the source of that is, but it appears to be it's correlated with being in the Medicaid group, so it could be related. Right.
The design here, I think the investigators would be comfortable saying it's a causal effect based on the design, but we could get into whether you're comfortable with using causal language. But just to finish out the mental health thing, they found statistically significant improvements in self-reported mental health and in proportion of people saying that their health was good or better than the prior year. And we talk about diabetes. Well, we talked about there was an increase in probability of diabetes diagnosis and medications, and those are both statistically significant. And you might wonder about cost of all this. There was an increase in cost, expenditure to the state of about $1,200. This isn't all expenditure to the state. It's an increase in cost overall. So people, who were not enrolled in Medicaid, they're just spending out of pocket. But the increase in overall cost of care due to Medicaid from all sources is $1,200
per
person.
Yeah,
per year.
And that's from their increased use of mammography and the other tests and et cetera that they had access to, presumably.
Right.
So let me play the skeptic here. A while back, and you'll tell me when, there was a famous study that was vaguely like this. It's not exactly like this. Vaguely is not the right word. But it was designed to see how people responded to health insurance. It was done by the Rand Corporation, and it was shocking and controversial and remains controversial. They found that people who faced, correct me if I'm wrong, people who faced lower prices used more medical care, as economics would predict, but their health outcomes were basically the same as people who did not get the benefit of those programs. You could say it's not surprising that people who win the lottery get in a better mood eventually, that they have fewer financial problems. That's not a very good test of Medicare's efficacy. It's a result of giving people more free stuff. That means they're going to have fewer financial problems. In other words, rather than expanding Medicaid, maybe what we ought to be doing is giving people money. So as the skeptic, of which I am, the Rand study, now this study, there have been other studies, Levy and Meltzer in 2008, Kroenig in 2009, that seem to suggest that health insurance does not have much of an impact on health. Maybe it makes you feel better. Maybe it might let you sleep better at night. It's not unimportant, but health insurance is a relatively expensive way to get those outcomes. And so the question is, as someone, and you're not alone, there are a lot of people who believe that we should be expanding health insurance and availability in the United States, either through public programs like Medicaid or other ways we could do it. Where's the evidence?
So I'm going to disagree with one nuance in what you said, and then agree with a lot of it, and then focus in on where the action is. So the disagreement, and this is all what's been going on since this latest study came out in the last week. The disagreement I have with what you said, or maybe what you implied, you might not have quite said it, but if you said it, I will disagree with it. So I'll put the words in your mouth.
That's
and then
fine.
I'll disagree
Go
with
ahead.
it. The disagreement would be this latest study, because of the power issues, basically the low sample size combined with the low reasonable expected effectiveness, basically, of Medicaid, is uninformative on key physical health measures. It's just the error bars are just too wide. Now, that doesn't mean it's possible that Medicaid had zero effect. That is possible. I think what it more likely means is that it means what I said. It means it's uninformative. But I think what's more likely true is Medicaid may have a small positive effect, and this study could not detect it. However, you're correct to point out that there's lots of other work we can look at, and including the Rand Health Insurance Committee, including the Levy and Meltzer study, and others. And I think when you look really carefully at those, in fact, the publications bear this out, and what the authors say is that where the action is, for most people, health insurance doesn't do much because most people are healthy. I mean, health insurance doesn't do much for their health, but it does a lot for spending. It does a lot for access. It does a lot for financial well-being and peace of mind and so forth. All those things. I agree with that. That's the part I agree with. For people who happen to be sick or poor, or both really, public assistance for taking care of their health care does have an impact. The Rand study showed that. Levy and Meltzer point that out. And so that's where the action is. Now, I think you're right to say there's other ways to help those people. And Medicaid as currently configured may not be the right approach. And I think that's completely valid discussion. But just on the evidence alone, I think the evidence is consistent with the idea that there are people for whom healthcare is helpful, but that's really not most people when they're healthy. And in our current system, health insurance does facilitate access to that help.
And let me just add one more troubling piece to this, which is we hear a lot about the value of preventive care, and I had Eric Topol on the program a few episodes back, and he made a shocking observation to me. This relates to this study, which is the Oregon study, which is that the statin drugs that reduce cholesterol, they don't reduce it for most people. And for the ones that have reduced cholesterol, it's not very well correlated with better health care, better health outcomes. So we have all these drugs that reduce cholesterol, but it's not clear that they reduce your risk of a heart attack, even though cholesterol has something to do with a heart attack, which is weird, but that's the reality. And so to me, and I'm going to put the shoe back on my foot in a minute because I'll be done picking on you in a second. But for me, the challenge is that shouldn't we just be taking care of catastrophic healthcare risks rather than pushing the country toward what to me is similar to what we do with Social Security, which I think is nuts, which is everybody gets it. Rich, poor, we all get it. We all contribute, we all get it back. And that allows us to do some subtle redistribution within donor payers and recipients. And similarly, we have a bunch of people who have good health and bad health. We have rich people and poor people. Everybody's going to get free health care, get to use the system without any worries at all, even though most of us, most of the time, don't have that much value from that privilege. And we end up paying a lot for it because we've lowered the cost artificially, the price artificially, and encouraged usage as a result, which pushes up the cost. So what's many of the people who who designed and executed this study are major proponents of the Affordable Care Act, including Jonathan Gruber of MIT. Where's the evidence for their viewpoint, given this what we've found so far?
Well, apart from Jonathan Gruber, I'm not actually sure what the position on the Affordable Care Act is on everyone on the study. And, he was involved, but he wasn't a principal investigator.
Fair enough.
And this study, in large part, I agree with what you said about providing public benefits, for everybody, rich, poor, sick, healthy, so forth. When you have finite resources, even accepting, which you may not, but even accepting that you're going to use public funds for support, those funds are finite. Society is only willing to bear so much. Witness the debate over tax rates and so forth. And given those constraints, it's perfectly reasonable to say, well, we're just not going to provide free health care to millionaires, but everybody gets Medicare. So
and not just that, we're not going to give my wife and myself an incredibly low price for our pregnancies and deliveries, which we had some control over, strangely enough.
Yeah.
It's not catastrophic. It's not unexpected. It's not insurance. I go to the doctor every year, every 2 years, depending on my schedule when I feel like it. That's a checkup. Shouldn't be part of insurance.
Right. So there's a lot one can debate. There's a lot of things bound up in all this, and that would take maybe 2 more hours, if not 1. But where I was kind of headed was, we spend a lot on Medicare, and that's for everybody once they reach a certain age, regardless of their income and assets. Although there is some means testing of the premium, but nevertheless, we also spend a lot on or don't collect taxes on employer sponsored health insurance,
which is
and
nuts.
There it's even more perverse.
That's nuts.
Because it's not only that rich and poor people alike are getting a benefit. Rich people are getting a bigger benefit.
Correct, because they have higher marginal tax rates.
Very strange. Very strange. You wouldn't. It's hard to imagine why you would design it this way.
You wouldn't.
Many of us, you wouldn't. Now, what we're spending out of public funds on Medicare per person is about on the order of $10,000 a person. And what we're foregoing in tax collection on employer sponsored insurance is about $5,000 on average for each insured worker and family. That includes family plans too. Now, what this study and what the debate is about in states right now is about poor people. I mean, legitimately poor people, objectively poor people. It's not a mix of poor and rich. It is a mix of healthy and unhealthy. But
that's correct.
These are poor people, and the cost under the Medicaid program of providing a benefit to them that, well, we can argue is it like employer-sponsored health insurance? Is it like Medicare? Yeah, that could be a debate. Maybe it's worse. Maybe it's better. Maybe it's the same. But it's akin to it. It's basic. Apart from dental and vision, perhaps it's pretty fun, pretty standard benefit package. The cost of that, for a variety of reasons, is extremely low, like $3,000-4,000 a person, and these are all poor people, and the debate right now is whether states should, with help from the federal government, expand their programs to cover everybody under that, so that all poor people have at least this level of protection. And is this study informative on that question? Well, I think it's more informative on the question of do poor people benefit from assistance? And in this case, the assistance was a specifically designed Medicaid program in Portland, or in and around Portland. I didn't mention that all the in-person stuff, so all the data in this study was in and around Portland, Oregon. Even though the expansion was statewide, this study was focused in the Portland area. Anyway, it was it was designed, around that program. But states have some flexibility to design different varieties of Medicaid. They may not have as much flexibility as you or I would like, but broadly, I think it does address the question whether poor people benefit from some assistance, and I think it's clear they do, and that's what you'd expect.
Yeah,
is that benefit, is the nature of that benefit worth the cost? That's a point one could debate. Could that benefit be reconfigured or delivered in a different way that's more efficient or helpful? No doubt it could be.
Yeah. So let me put the shoe on my foot. I don't know what the right metaphor is, but some of this discussion, and I'm not talking about our discussion, I'm talking about the general discussion in the blogosphere of how the reactions to this and how there's a lot of jumping up and down by one side and a lot of, it's no big deal on the other. So the people like me who are, and this is not my reaction, as I made clear earlier, but a lot of people who don't like the Affordable Care Act or don't like Medicaid generally, they've been jumping up and down saying, see, this proves we've been right all along. Medicare's a waste of money. The people who like the Affordable Care Act, who like Medicaid, want to see it expanded, say, it's only 2 years. It's underpowered. It's only one survey. Reminds me a little bit of the recent empirical work that's come out about the minimum wage that says it doesn't have any effect, doesn't reduce employment, doesn't hurt low wage, low skill workers. It actually just gives them a nice raise. And I have to say that when I see that literature, my first thought is to explain it away, because I believe that there is an incentive effect to employers of making workers more expensive. So I say things like, well, when you have a relatively low minimum wage, as we do, where only a few people are affected by it, it's not surprising that when you raise it by a relatively small amount, still only affecting a small number, it's going to be very hard to tease out the effects because most people simply aren't affected by the law. Obviously, if the minimum wage goes from $7.25 to $9.15, it's not going to affect your salary or my employment or your employment. And so an econometric study that tries to evaluate the impact will often, I would say, and it might not find any impact. Of course, all the studies that found a big impact, which is what the previous literature was, my side waved those around and said, see, it has a big impact. And when these new studies come out, they say, well, it's a small population. That's a phone survey. It was done. The methodology's wrong. So I just want to reflect on the fact that it's very easy to over-exaggerate the significance, and I'm using that in the non-statistical sense of the word, the importance of any particular finding because of confirmation bias. And so I'm just curious if you want to just react to that in terms of the people you know and have talked to, the people you blog with. Is there some hunkering down? And we saw the same thing with Reinhart and Rogoff. The people who've been talking about debt, the result still holds. Those who were worried about debt said the result still holds. People on the other side said, see, we told you all along this whole thing's is a sham. We don't have to worry about debt. Just reflect on that.
I think that's right. I think there is some hunkering down and shifting of emphasis to just focusing on the statistically significant findings and sort of explaining away those that aren't. I've seen that. I don't like it. I don't like to see that. That's not how I've approached it. The way I approach things is, one study is not definitive. You need to look at a body of work, and one would hope that a body of work using different methods, different data from certainly different people, hopefully people of different ideological persuasions, if possible, if they all are kind of pointing in the same direction, or not all, but a preponderance of evidence in the same direction, it really increases your confidence that that's the right way to think about it. Having said that, I think you also have to weigh the methodological strengths and limitations of each study. So in this case, it's a randomized trial, randomized controlled trial, albeit with some leakage and crossover and so forth that they addressed with a statistical approach that's quite reasonable and accepted. And I think for that reason, I think this study carries a lot of weight. However, one of the limitations of the study, and this is something that I was a little bit distressed to see, very few people recognized on either side of the debate. One of the limitations is it just didn't have enough sample for certain questions. Had enough for some, not enough for others. And, I don't think anybody would, no rational person would want to base a decision on, undersampling. And like you gave some examples earlier, just, if you're going to try to assess something, you want to make sure you sample enough of the world to be confident that you're not just reacting to noise. So on some questions here, what is reported is not that much better than noise. Now it is better than noise because, they had some sample, but the error bars are really big. And so, and this is something you can just compute, how big a sample would they have needed, and therefore this one is underpowered and that one isn't. And it's objective. You can do that on every study. You can go back to every study and do that if you want. And so I was a little bit, I've been a little bit uncomfortable with some of the responses to this, either accepting the results that aren't statistically significant as informative as accepting them as informative or more informative than I think they are. I think some of them are relatively uninformative.
So here's how we could imagine life working. It doesn't work this way, right? But we could imagine the following. And again, I'm picking on you a little bit, but I could easily pick on myself. So
I've been much worse picked on.
Yeah, it's mild. So here's the world we could live in. So you said the sample's underpowered. Again, even though I like this result confirms some of my biases, I think 2 years is a very short time. I know some people are confident it would be a long enough time, but let's suppose I said to you, okay, we're going to expand the time span of this study. We're going to run it for 10 years, not 2, maybe 30 years. Let's run it for 30 years. Let's quadruple or sextuple the sample size. I'll make it as big as you want. Make it 50,000. We got 50,000 people here, 100,000 people in each group. We'll run it for 20 years, and we'll make a deal. And this is along the lines of former EconTalk guests Robin Hanson or Brian Kaplan. They're both big on bets. And I'll say, look, if it comes out that even then it doesn't have an effect, would you change your mind?
Oh, yes, I would.
Right? You say you would.
I would.
And again, to put the shoe back on my foot, okay, well, if you raise the minimum wage to $25 an hour, well, then you'd find an effect. But then I have to be honest with myself. When they raised it from 5 something to 7, from 5, I think it was 5.15 to 7.25, I would have thought there'd be a big effect. Some people claim there is. I don't think it's pretty hard to tease out of the data. So the question, I think for most of us, when we get these kind of results that don't confirm our priors, we usually find a way to say, I think, the methodology, they're looking at the wrong measures, they didn't do this or that right. It's very hard to find a definitive study, and it's not the way the world is.
Well, I don't know how many, probably, I think you're right. And probably everybody, almost everybody, says they're not biased.
They do say that. Yeah. I like to admit it, Austin. That's one of my thrills in life is admitting I'm biased.
The thing I will admit, and this has happened to me, is I actually like it when what I thought was true is overturned by some evidence that I'm convinced of. I actually really like that. I would have been more pleased to have this study come out and say, well, we had the power to detect this minuscule increase or minuscule improvement, and we couldn't even find that. Look at this error bar. I mean, and we couldn't even find it. And
but you're unusual.
A number of people reacted that way. If you just look around in the first few days after this study came out, a number of people said, okay, we're just basically willing to agree that Medicaid maybe doesn't have a big effect on these health measures or on some basic health measures that we thought it would. But look at the financial benefits and look at the access and look at the mental health. Now the mental health result that is really, well, provided you believe what it's saying, and many people do, it's really big. I mean, even if half of it is true, it's a big result. there's a lot of well-being there. In fact, in the prior paper a year ago, the authors estimated, and they did some back-of-the-envelope calculation using some other work, that the improvement in mental well-being, if you wanted to get that level of improvement from an income enhancement alone, you'd have to double income. So it was a big effect. That's
the only problem with that result is it suggests that for people who are switching jobs and are going to double their salary, they would still take the job if the employer said, "Hey, we'll give you free Medicaid, we'll give you free access to Medicaid." But I'm being facetious. Obviously, if that's a real effect, that's quite extraordinary. And there is the question about whether there are other ways to achieve it. But that statement about doubling income suggests it would be very expensive to achieve it in other ways. We'd have to know if that was reliable. I don't know.
Oh, sure. I'm not saying we should base policy on that alone, but it's just a way of interpreting the result. In any case, as it turns out, I just don't think this study is as informative as some people think on certain measures. And I did this power calculation. It's on my blog. In fact, I have 2 posts about it, and I was really worried I did it wrong, because I don't do power calculations very often, and they can be tricky, and getting the statistics right and so forth. And so I did it, and I said, well, what I calculated was the sample would have had been about.
I read the post. You're very cautious. You're very cautious.
Well, the result was surprising to me. It said the sample would have had to been about 3.5 to 5, depending on the measure, times bigger. And I'm looking at it saying, but how could that be? 5 times bigger. That's a really strong statement about how underpowered this was. And so I calculated a couple different ways. I went online to get a different tool so that, maybe I was using Stata incorrectly. And I had some biostats people look at it, and they all checked off. They do this for a living. And another professor I found on Twitter had done his own calculation. He said it was right. And another guy, this is the great thing about blogging, another fellow in the comments went back. I didn't do this by formula. I just plugged it into, these online calculators. This other guy said, well, here are the formulas, and I just, worked through the math, and I'm getting a different result. And we went back and forth and figured out why he's actually using the formulas to calculate something different than I was. And so we worked it all out. The point is, this is really it is really a valid objective statement that it was underpowered on these questions, and I was so surprised by that I didn't want to believe it myself, but it's just what it is.
Yeah, and then I don't, when I express my skepticism about our ability to deal with bias, I don't want to suggest that people can never confront things honestly. Obviously, we do sometimes face evidence that forces us to change our mind, or sometimes when we're skeptical about the importance of result, we should be. Maybe it's not informative. And of course, again, for those of you who haven't been following this, you'll now start to notice it in the paper and in the blogosphere, and it's going to be an issue that continues to get discussed. And I want to close with not the implications, just some factual stuff, because I don't know. What does the Affordable Care Act have to say about Medicaid? And because I know that's going to interact with these findings, people are going to be yelling about them in the next election and elsewhere. So, what does the Affordable Care Act require or encourage Medicaid at the state level to do?
Yeah, I'm really glad you're coming around to this, because this is the key question. So, and you mind if I just take a minute to do the history on this?
No, go ahead.
Going back to so the designers of the law, and as it was passed, the whole idea was every state was mandated to expand Medicaid up to everybody with up to 138% of the poverty level. You'll see 133 written, but there's a 5% income disregard, so it's effectively 138% of the poverty level. And every state had to offer Medicaid to everyone, with that income or below. And then this was debated in the courts as possibly too coercive. So there was a claim by some states that this just coerced states into doing things they don't want to do. And the coercion here was that if states didn't make this expansion, the federal government could withhold all funding for all Medicaid, even the existing part of the program. And so it could just, either a state does this expansion or they have to wipe out their Medicaid program, was basically the stick behind this. And if that's the deal, I mean, there's no state that's probably gonna walk away from the expansion if that's the deal, because it's very coercive. Not only would it affect a lot of people in the state, but it would devastate the health system. I mean, there's a lot of money flowing to hospitals and doctors, and state legislatures just not going to walk away from that. So this went all the way to the Supreme Court, and the Supreme Court came out with a ruling last summer that said, well, everything's fine. And they ruled on a lot of things about the Affordable Care Act, including the mandate and so forth. Basically, everything's fine with the Affordable Care Act, except we don't like this Medicaid coercion thing. We don't like the way the expansion's done. Let's make it optional. The court just said states have the option to expand under the way the law specifies, or they could not expand and just keep the existing program, and then leaving many people without the option of Medicaid. And so now every state is deciding whether they expand or not. And now what expand means is not just one thing. There's actually quite a bit of room in terms of how Medicaid is specifically designed. And Arkansas, for example, instead of expanding in a sort of traditional public program way, they've decided to expand by just having all of the expansion population be eligible to go get private insurance through the health insurance exchanges that are going to be set up. So instead of having a separate public Medicaid program, they're going to just put all those people on the exchanges. And there's a whole debate about, will that cost more, and what are the advantages and disadvantages of that, and so forth. But the point being, states have the option to not expand Medicaid at all, or expand it in some, there's a range of options that they might consider in how they design their expansion.
And let's close with your thoughts on how this study is going to affect that outcome.
My prediction is this study will be used to, in part of the debate. It's a little bit about like the Reinhart and Rogoff work, where you can say, did this study influence policy, or was it just used to justify positions that would have been taken anyway? But I think you'll have this study cited by state legislators and others debating whether they should expand or not, and some of them may cite it and say, look, Medicaid, this study showed that Medicaid, there wasn't, didn't improve physical health, or something. Or they might even just say it didn't improve health at all, here's the study. And I'm sure some people will use it to say, look at the result on depression, look at the financial benefits. This is hugely valuable. And I think very few people will say what I would say, which is this study showed some positive benefits of Medicaid, and this study was uninformative on some others. And meanwhile, the actual choice here, is not, some other thing like giving people cash. That's just not on the table. The choice is whether people get some assistance or none, poor people. I come down on the give them some side rather than none. But I think very few people are going to use this study in that way.
Well, thanks for helping us understand it. My guest today has been Austin Frakt. Austin, thanks for being part of EconTalk.
Thank you. It was my pleasure.
This is EconTalk, part of the Library of Economics and Liberty. For more EconTalk, go to econtalk.org, where you can also comment on today's podcast and find links and readings related to today's conversation. The sound engineer for EconTalk is Rich Goyette. I'm your host, Russ Roberts. Thanks for listening. Talk to you on Monday.